Good afternoon. That was great. Thank you, gentlemen. It was some great insights there. There's one point that I heard, and that was the concept of stressors by design as opposed to reacting to them, which was sort of a school of thought for cybersecurity called anti-fragility, which is pretty interesting to look at that versus typical resilience. Without further ado, I have the pleasure of introducing this conference with Jim Feen and Matt Shaw, both of Southcoast Health here in Massachusetts, where I am. This is a selfish act because the first time I heard this presentation in a Chime level 10 validation on site, I just said this is something that people have to experience themselves. I don't want to go much further without introducing my guests. The way I like to work this is to have them introduce themselves and talk about what they do in a day in the life of themselves. And then we'll sort of move into the framework for doing this war game in an organization that has 8,000 people, I think it is, and all the trials and tribulations culturally and technologically that go along with that. So, Jim, I'll start off with you for an intro and framing the session, and then we'll move on to Matt.
Yeah, thanks, Frank. It's great to see you again. Jim Feen, I'm the SVP, Chief Digital and Information Officer for Southcoast Health. As Frank said, we're in Massachusetts. We sit between just above Cape Cod, but between Providence and Boston. And just a quick on me. I've actually been with Southcoast for 17 years and came into this role roughly 8 years ago as I worked my way through the ranks. So I've been here some time, and I was actually in industry working for an EMR vendor that everybody knows here, and so it's been a nice story for me personally. I have the pleasure of working where I live with my family, and I'll turn it over to Matt for his introduction for the good work he does for Southcoast.
Sure. Thanks, Jim. Matt Shaw, Chief Information Security Officer at Southcoast. I've been at Southcoast about 7 years, in the CISO role, 3 years. And prior to that, I was in community banking industry for about 30 years. So in terms of the day-to-day, I have the security engineering teams that roll up to me, the GRC and third-party risk teams roll up to me, and also Epic Security roll up to me as well.
Great. So a couple obvious rookie questions here that I'll ask, but I'll ask them nonetheless. Um, First of all, people are sitting in a room, and so when does something pop that says, well, maybe we should do something more dramatic? And without maybe even at that time realizing how dramatic it was, other than knowing that 48 hours is a damn long time uh,
Yeah.
for an outage. So how did it spark? What was the flame?
Yeah, it's a good question, Frank, and it's something that I think selfishly in a lot of the good discussions so far in this over the last hour and a half, really, for in industry perspectives, from Nitin to the discussions around AI and work process automation to some of the things that Dave and Mark were just mentioning around operating through a bad day or a series of bad days. It to be very, very blunt, it was the change event of almost 2 years ago that started to, I think, set different questions for providers, for staff, for leaders in our organization. We had invested so much money and time and talent in the prevention and detection and education and all the tenets that you saw in the prior presentation on a healthy and robust cybersecurity program. But what happens when you start to think about protecting the patient care, when you think about true business resiliency and viability of your programs, that was the spark. And this realization as an organization that we've done all these things, but I think with an unintended consequence of putting incident response and in all of the run books that happen that we prepare at tabletops for what happens when a bad day happens. Well, you got to make sure that the rest of the organization is coming with you in that readiness. And I can tell you that as the person responsible for the programs, we weren't there. And I think everyone in our organization would tell you that we weren't practiced. We have knock on wood, we have a good history of most major events happening overnight. Everybody takes their EMR down at night to run upgrades when it makes sense. So you got a third shift that's really well in tune. Your EDs are really well in tune with what has to happen during the next quarterly upgrade, right? Well,
Yeah.
if the rest of the organization isn't with you, and those things started to come to light after the change events, and it was actually a med exec meeting that I was sitting in. I'll never forget it. Or what if we start to do things differently in using upgrades and planned downtimes across different shifts as a way to get the organization, up to snuff with the good things that were happening on the technology front.
Matt, were you with it from the beginning, or did you have to be brought along on this?
I was in it. I mean, since I've been, doing my teams manage we kind of manage the cyber renewal process, and we conduct
Mhm.
cyber tabletops as part of that. And so one thing that I had been proposing is, BCP is not an IT owned function, right? So let's shine a light on other parts of the organization, right, and get them thinking critically about, downtime procedures, et cetera. The IT teams and security teams, we kind of run through that and pretty regular, in terms of if there's a disruption or there's something else. So we have a good cadence down in terms of that. But I think bringing in the operational folks, I think was a key component to this as well.
Interesting. I mean, we use the word scalability in this business over and over again. So I think when I look at what you did, there's that balance of saying, okay, we want to make it meaningful and be across enough scale that we get outcomes out of it, to use another word we use all the time. And then yet we want to make it manageable because this is going to scare the bejesus out of people, and we've got 8,000 of them that could possibly touch that. Jim, how did you decide on what the scope of this was going to be, or did that sort of migrate as you started doing it?
Well, it came to be, when you really start to think about the mechanics, a couple of things that we want to take it out of this. Number one, we have a big investment, like probably everyone on this call is in disaster recovery operations, secondary data centers, et cetera. And how do we test those procedures and actually run the operation from them? But two, how do we start to target the first shift and the second shift that we knew were real weak spots for us? And you start to work your way back. We're linking, for us, Joint Commission and the concept of high reliability and linking those things to a patient safety objective. What are the things that we can and should do that are going to really get the organization uncomfortable, where we're going to be in a learning environment, and two, how do we do that in a really safe way where no one's put in harm's way? And looking at the systems that would conceptually remain available during such a test. That those were the discussions we started to have in very private and targeted ways with specific leadership groups to talk about the concept of an unplanned, downtime of our Epic system. Oh my gosh, what the heck are you talking about? But what are the benefits of doing something like this? What are the anticipated learnings? And that those are the types of conversations that we started to have that led us to the plan that came to be.
I spent a little bit of time in the intelligence community, so I know that keeping secrets is not easy. I mean, how did you determine the need to know list? How far did it go? Because you talk, I mean, the in the end result, it has to be patient safety. This is a great experiment. We're going to be on a Chime podcast and talk about it. But yeah, when the rubber hits the road, it's like somebody could lose their life if it doesn't go well.
Yeah, no, it's very real. And it's something, as a member of the senior leadership team here, it's something we talked about. How far do we stretch this? And the answers became relatively easy as, members of my senior leadership team were engaged, from nurse exec to med exec, to targeted physician governance bodies. We're pretty well structured here. That's, a favorable thing. And two, how do we getting those groups involved? They're, out of 8,400 employees now and 1,100 on the medical staff, I tell you that maybe 2% of our organization knew this was going to happen, all the way through to our board. So when you think about, in the rationale for that, I think there was common agreement that um, doing this as an unplanned exercise and a true simulation of a bad day was how we were going to yield the highest impact and the most amount of organizational learnings with patient safety in mind. And yes, it was controlled. We did things like, our internet was not disrupted, our phone services were not disrupted. If you're, for those of you who are Epic clients out there on this, things like shadow read only were going to be available. So we knew we had backstops to this that were going to allow for safe care to continue. How the organization knew to rely on those through muscle memory was one of the greatest learnings, I think, of all, and making sure that there was a uniform understanding of what had to happen. And the key conduit for us and the safety valve was having our incident command center open, where I'm in a room, in a boardroom with other key members on an incident command call to make sure that every member of leadership had immediate answers to things that were happening on the front lines, that where there was perceived risk.
If there's anyone on this call that wants to try this, are there anyone in the group that sort of govern it that you would suggest that they have that they wouldn't normally think of? I mean, obviously somebody like Matt's going to be on the team, but was there a lawyer on the, I mean, I just want to figure out who are not the normal suspects that ended up being in the need to know category.
Yeah, no, it's a good point. Yes, our chief legal officer was in the know. Um, Executive over risk management, compliance, all those key players that you'd expect to be around the table were in the know.
Mhm.
I think,
I think one of the ones that people might not expect would be the brand folks and the marketing folks, because we had to be careful about making sure that people knew that it was an exercise once it began, because if word gets out that South Coast is under cyber attack, it could have really bad consequences in the
Sure.
media, right? So we brought them in early, and they knew it, and our messaging was clear in terms of this is a drill only. This is a drill only, and we kept that clear throughout the exercise.
Yeah, and I know that from my previous work with you folks that you guys are very risk cautious. I think got to meet your risk guy a couple years ago, and it was impressive of how you think a little bit differently in that category as well. So okay, we finally go through the thing. It's given the papal blessing. Okay, we're going to do this. When you get down to the blueprint of what you're going to do, how do you decide two closures of Epic, as I understand it? How do you come to a decision on how far we want to take this and how we want to sort of expand it if we can?
yeah, but Matt, do you maybe want to speak a little bit about the bookends of the tabletop that led into the event?
Yeah, sure. So as again, we did get as part of the cyber renewal, we started to talk about the tabletop, and we brought this in, and we brought in the some of the operational teams really to get their critical thinking started in terms of what would happen if we did have a ransomware attack, and really got them thinking. We had a couple of sessions with teams, and we surveyed them on how well they thought they were prepared, etc. And little did they know we were going to have the actual event a couple weeks later, right? So we actually surveyed them after the fact, and based on what they had initially rated themselves and what they learned in the test and how they performed in terms of critical thinking, etc., their surveys actually came back that they were more prepared. I mean, of course, there were lessons learned about, enhancing playbooks and certain things that they took away that they, had challenges with, but it was good results in terms of that. And the other thing is it was, months long preparation by the IT teams, and just to kind of really plan things out, make sure that things talk, devices were talking to the backup, instance of Epic, et cetera. So it was a lot of work and preparation from the IT side as well. So
So we've gone from decision, we decide how we're going to do it. So I think we're moving into the what happened then
Yeah.
part of the story because I know the first thing people would say would be, "Holy, fill in the blank."
yep.
What's go, what's going on here? The except for the 770 people that really knew something about it. So what was sort of the first impression that you got? First of all, ones that you expected, like, oh my God, it's down, and part two, what do I do now?
Yeah, and that's where the run book and the script for incident response really took over. You know, the organization got a page, so it's just like any following a process for when something bad happens or there's an unplanned event. That page notice went out that Epic was down. That was real. Epic
Mhm.
did suddenly went down at 10 o'clock on August 14th, 2024. And the rationale was that we were in a cyber simulation exercise. So, and it was with very clear direction that you are on downtime procedures for anything related to care in the EMR. And what happened at that same moment, so that we were truly testing also the incident command procedures and the activation of an incident command center where, you know, I'm in the room, our chief nurse is in the room, our chief operating officer is in the room, the SVP of risk, who you met, Frank, was in the room, and we all had specific roles. You know, it's the activation of a Teams link for leadership as they're interacting with us, and it's, you know, you start to go through the run book of, okay, what's down and what's up, and what's down is our engineering team behind the scenes was actually,
Mhm.
they took the system down, they prevented further logins to Epic, and they started migrating or running through an exercise to begin running Epic from our disaster recovery site. Um, by effort, they could get through that exercise in roughly 20 minutes. We chose to make it 2 hours, so that there was which we through governance agreed was a healthy stress test of downtime procedures mid morning. You know, mind you, in the middle of the week, where we were going to get the greatest value of that exercise and start to, you know, to be in position to start yielding learnings of the things that, you know, did not go well or go to plan or according to what the downtime procedures said should happen. And we have a myriad of things. You know, we had to, I think an earlier presenter talked about the, you know, the idea of that many physicians have never even trained on paper. You know, we had providers who had never handwritten an order before, all the way through to, you know, what happens when you don't have prescription paper in an Omnicell to write you know, a narcotic, because they've never had to do that before. So the list was long, but in those 2 hours, you know, it spanned an event where we brought the system back in the DR, and one of the things we were very clear on is that those 2 hours could easily be 3 weeks
Mhm.
or four
Yeah.
weeks in a true event, and we all know the statistics that go with that. Um, but then repeating the exercise where we brought the system down and back into production state, we then tested the same exact exercise on the second shift 35 hours later. And they second shift now had to go through the same process and the
Mhm.
learnings that we pulled from them. You know, we have a lengthy list of those things that didn't go so
Yeah,
well
I'm
we
anxious
weren't
to
even
hear about
learned.
that. How would you characterize your reactive capacity? We plan for this, and we have people in the mission control room here. Did we have enough of them? Or do we over or underestimate or hit it right on what we expected the reaction to be and how we respond to the constituents?
Yeah, the it's a really good question. I think we felt adequately staffed from an ICC standpoint.
Hmm.
The one of the biggest learnings of that ICC was the pressure to perform element, and it was also stated, I think, by Mr. Duclos earlier around the stress factor. You know, and some of the interactions that we had with providers who were highly stressed, you know, and some of the bad behavior that came out of this, from how, you know, the comments of, how are you going to pay me to do my notes tonight, because, you know, I shouldn't have to worry about this. So those were things where, you know, our chief physician execs did have to get involved in some of the behavior that was exhibited, but it became a learning conversation and a dialogue that we're fortunate to have, you know, highly resilient systems investments here. It doesn't mean this can't happen tomorrow. And what do you, and so it was more good conversations, I think, that came about like that.
Matt, how about your constituents there? How did they react, and what were some of the more CISO side of
We
the
were,
change and
yeah, we were
challenge?
really we were really more behind the scenes with the tech teams. We had, you know, making sure that things, you know, that were needed, we addressed. We had some tunnel issues and, you know, some of that stuff, but we were really more in a supportive role. So we didn't really run into, you know, we were all on standby, but we didn't really run into anything that was significant from our standpoint.
Great,
Yeah.
great. So moving on here, we have about 10 minutes left. I want to get into, we've gone through this war game. There got to be findings that we thought would happen. I'm always, as everyone, interested in the ones that we just never thought this would happen. Starting with how to write a order a prescription on paper. It's sort of funny because one of the previous sessions was talking about moving back to paper. So it looks like that's becoming strategic and tactical as well. So Jim, what are the headline findings, and then what are some of the ones that really are equally as important, but not what you might expect?
The headlines are, I tell you, as much work and energy that healthcare has put into integrated systems over the last decade, the problems that you have when you do something like this become that much more complex. So I tell you that the operations functions, when you think about prioritizing non-critical results in your lab or in imaging, those conversations from the clinical front lines back to the ancillary services were where it was a big headline for us, that we had a lot of work to do to better organize, whether it's in your pharmacy, whether it's in your lab, whether it's in imaging, how those things work. That's pretty nailed down for criticals, right? There's always a call, there's follow-up, you're making sure the Swiss cheese doesn't line up, but what happens for the normals? And so I tell you, the multidisciplinary integration points that you take for granted are the ones that are going to get stressed the most. And that's where our focus has been, in bringing together different leaders and different staff from those areas of the organization to rethink, some of the inner workings of those downtime procedures that just didn't account for some of the more routine functions that they certainly take for granted when the EMR is active.
Matt, major finding on your side that I think the other part of this is that this was, I know it was well planned for a long time, but it sort of was an acute instance that when it happened, and then we have to look at longitudinally how we keep this thing going rather than doing the high five party afterward and saying we got through this and let's move on to the next thing. So
Yeah.
what's changed your life about this, Matt?
I mean, I'm happy for the fact that we did this and take away the lessons learned. And I think it was important to show that, again, business continuity is not just an IT or a security problem, right? And I think everybody has to be prepared and make sure that they have what they need, right? Especially, I mean, this was relatively short as compared to an actual ransomware incident, right? So really thinking about past a few days and, as it extends into a week, 2 weeks, what do the teams need, and having them make sure that they have those things in place to the best of their ability. So I think that was one of the big things. Again, by kind of transferring it to the operational side, the security team was out of it fairly quickly. It was really more of a this is the scenario kind of thing. So we really did, it was handed over to the other teams pretty quickly in that test.
And I tell you, Frank, in our post survey, 100% of leadership that responded to that survey said this was a valuable activity and we should do it again. 100%.
Well, don't hear that very often. So I'm sorry. This must have been, again, I might be grasping here, but I just look at the number of people that get involved in this. This must have been sort of a heyday for the human resources department in terms of stress, literally stress testing in a way that people didn't know it was stress testing. It was stress. Did you find stress, any well-being or stress findings related to this, with obviously with what's happening with the burnout factor,
Yeah,
especially among CISOs, which is one of the highest burnout groups.
Yeah, I'd tell you that the providers were the biggest hit there. They're the ones not engaged in the incident command center function, or a lot of the leadership communication. They're on the front lines, right? They're with patients, they're in exam rooms. That's where we saw the stress tip, right? In some of the areas that were they've got this resource, right, with an incredible amount of information that's being used in clinical decision support. When that comes away and you've got a patient in front of you, what happens? And how that affects how they have interactions with patients. It became a discussion point, right, in both our med exec and our board of governors with our providers on what are the coping mechanisms and tactics that they should be thinking about when it relates to downtime, because there is no guarantee on any of it. And so it became, I think, a healthy conversation. It never went as far as HR. We did, like I said, have to get leaders involved in some follow-ups of some of the bad behavior. Sure. But I tell you, it led to more constructive conversation around what we can't guarantee and what they've got to be ready for professionally should and when this happen again.
How about the training aspects afterward now? Where do you build this into sort of in-service training that if this happens again, not just be aware of this, but also just like we do with phishing training and things like that with cybersecurity. Is there any new training aspects that this spawned?
Yes and no. I tell you that the hardwiring of downtime procedure review has become a mandatory exercise. Downtime readiness oversight is a new chartered function for us in 2026 that's going to just be in tune with all of those activities. And I'll tell you, second to that is that the favorable commitment by my boss, the CEO, all the way through the senior team, through leadership to continue this. We're now rotating our Epic upgrades across all 3 shifts. So it's no longer just a third shift activity. It's going to be first, second, third. And we don't even call it downtime anymore. It's business continuity readiness training. And that's an Epic upgrade. But the focus is not on the technical element of it. The focus is on the operation. It's got to continue through it. So we've completely flipped the paradigm of how we handle upgrades, when we do them, and the purpose of them. It's not just a technology thing anymore. It's not just getting the latest upgrades in your EMR.
How did you bring in some of your vendor partners after the fact, or even maybe in secrecy before the fact?
Well, the EMR vendor was number one. They knew what was going on, and they're actually it's kind of funny to having them trying to talk me out of this all the way to for those of you that are clients of Epic, being asked to speak at UGM on this was a pretty nice shift.
Oh, I think so. Yeah.
And why we want to, we're since then trying to talk with other organizations that are now contemplating, the same types of exercises.
Yeah. So I'm glad you brought that up. And for our closing question, so our audience is here. We've got 240 listening to us right now, and we've got 500 registered. I'm sure after all your talks, somebody comes up to you after the panel and takes you off to the side, gives you their business card and said, "We're thinking about doing this." But so what would you advise people? Obviously, then having the boldness to do it. What would you suggest? Even more important, like don't even try this unless fill in the blank.
I think we're beyond the don't even try this. I think I'm a heavy advocate on why this should become a standard operating procedure. But I do think it starts with people like us asking the question and asking some of the harder questions around operational readiness, because it is a gray area of ownership. We're Matt and I have very clear roles in this, right? But mine extends a little further in what I do, and start asking the question around comfort to what happens when, and never waste an opportunity in crisis, and going back to the change event, right? And if we're not asking hard questions around our readiness to make sure we're in a position to provide safe care, what are we doing? And I think that's how the conversation starts to start. What body can have oversight to something like this? Do we even have one? I think that the function of tabletops is good, but you will never get the institutional learnings and hardwiring of downtime process unless you're actually testing it.
This is great.
For sure.
Fantastic session, guys, and looking forward to the next go to see with or without surprises how that turns out, and would love to talk to you more about the learnings as they proceed over time. So, without further ado, being sensitive to time, I'm going to turn this over to Lisa Gallagher and her next panel. Again, thank you to Southcoast for some great insights.
Thank you.
Appreciate it. Thank you.
Pleasure.